COVID-19 Vaccination Essential Series that's brought to you by Rutgers, Robert Wood Johnson Medical School, the New Jersey Department of Health, and the Nicholson Foundation. We know you need this important information, and we're here to answer your questions and address your concerns. My name is Mary Bridgman. I'm a clinical professor at the Ernest Mario School of Pharmacy at Rutgers University and a clinical pharmacist at Robert Wood Johnson University Hospital in New Brunswick, and I'll be facilitating this morning's discussion. For anyone new to Project ECHO, the rapidly changing situation with COVID-19 really necessitates a responsive, fluid, and interactive communication strategy with the fast-track rollout of the vaccines for healthcare workers and long-term care residents in particular. These sessions have really been designed to address your questions and to provide you with the latest information on the vaccination rollout plan. The purpose of our first session today will be to provide you with an overview of the safety of the vaccines and the eligibility for phase 1A of the vaccination rollout plan. In today's session, we'll be hearing from members of the New Jersey Department of Health to learn more about these important aspects of the vaccine rollout. We appreciate all of the questions that you submitted upon your registration. You may also submit questions using the Q&A feature in Zoom during our presentations. We are sensitive to the urgency of your requests, and we will certainly make every attempt to answer as many of the questions as possible during our extended question and answer period. The session is also being recorded and will be accessible within 24 to 48 hours after our session on the Rutgers Project ECHO COVID-19 website. The website will also include the links and resources shared today, as well as the recordings of our session. Finally, I need to point out that as the timeliness of this content seems to change hour by hour and day by day, if you are viewing this content or this recording at a later time, realize that this may not be the most current information at the time you are viewing it. Note that information and websites for the New Jersey Department of Health, the CDC, and covid19.nj.gov are resources for healthcare providers, and these are provided onto the flyer for our sessions, but also will be redistributed after our call today. To begin with, I want to introduce Dr. David Adenaro, the Deputy Commissioner of the Public Health Services, the New Jersey Department of Health, who will provide us with the welcome for today. So thank you for joining us, Dr. Adenaro, and I believe you're unmuted.
I am. So good morning, everybody. I'm so excited that we have started this series. Really appreciate everything that you all have done to arrange this. Looking back over the last 4 or 5 months from the summertime when we established our vaccine task force, and really we're excited to work on the idea of a COVID vaccine prospectively and to have everything ready, to now where we're anxiously awaiting what happens in Washington with both the FDA and its various subcommittees to get us this vaccine. It's really an incredible thing. I think this series is great, and the ability to focus on these individual subjects I think are going to be pretty amazing. I really just want to prepare everybody for how fast and dynamic this is. So many of the things that we're talking about today are a little bit different than what we envisioned a few weeks ago, and probably what we're going to be saying today. Some of it's going to be a little bit different than what you're going to see happening over the next few weeks. I'm really excited that Dr. Bresnitz is able to really talk about the prioritization and a lot of the information around that, and have people like Amanda and Noel and Jennifer on the line also to give perspective as needed. And again, I think for all these sessions, the ability to also answer your questions are hugely important. We really think that anybody who's attended one of our sessions as a stakeholder gets activated. So the things that we're going to be looking for you to do as we move into this is obviously you're getting information, which is fantastic. And we hope that you then take it and get it out to your constituents and colleagues. And the next part obviously is to be able to participate as much as possible in our processes, to keep getting the information that we're going to make available. And obviously, I think our biggest interest is when it's appropriate for you to be vaccinated. We hope that you will join us in getting vaccinated. really, I think the most important part is for me to let the others on the panel begin to present their information. And I know that if this group is anything like the ones we've had before, you're going to have a ton of questions and really want to take as much time as possible. But again, from the Department of Health, thank you for everything you've been doing during this pandemic. And thank you for what we anticipate is going to be a great deal of support from you all as we're moving forward with our vaccine campaign.
Thank you, Dr. Adenaro. Thank you for being here today and for your support in this important initiative. We'll move forward with our first presentation, an overview and summary of federal approvals process and vaccine safety and efficacy data to date, which will be presented by Dr. Eddie Bresnitz, a medical consultant and chair of the New Jersey Department of Health Professional Advisory Committee of the New Jersey Department of Health. Dr. Bresnitz, I believe you're here and you should be unmuted. We'll pull your slides up.
Great. I think that these perhaps were not my slides, but David's. But I can go through these. Essentially, we do have, as David may have mentioned, that we do have a state plan. Here it is. If you go back a slide, I just want to make sure that people understand what our goals were. One slide back, please. And this was, as stated on the slide, provide equitable access to all, well, not that far back. Thank you. Provide equitable access to all who live, work, and or are educated in New Jersey, achieve community protection, assuming vaccine effectiveness or efficacy. And we do know that, and I will get to that data very shortly. And there will be availability in a phased approach. And then finally, and probably most importantly, the most important purpose here, other than providing information to attendees, is to build trust in the vaccine itself and the program that we're launching in New Jersey. Next slide, please. We do have a plan. It's been posted to the website. It was submitted to the CDC back in mid-October. It's changed dramatically since then, as David mentioned. It's progressed from what was initially in an embryonic phase to a much more mature thing, and it's ready to be given birth when we get vaccines next week. Next. Let me move on from here. Let me skip this slide, please. And so this is what we need from you. We know that as you registered, you provided some questions to us, and as Mary said, we've looked through those. You can submit them through the question and answer box as well, and we'll take a look at those. So we have some idea of what you are interested in, and I hope, at least in my presentation, to address many of those questions. But of course, if not, we'll be able to answer more in the Q&A period as well. Next, please. And get vaccinated, as David said. We all need to get vaccinated. And I hope that after my presentation, you'll feel more knowledgeable and certainly encouraged about the safety and efficacy of the vaccine. Next. Okay, that's who I am. Next. So there have been a lot of vaccines in development. There are many that are being developed around the world, including in the US. I'm going to focus today's presentation on the two vaccines that are closest to utilization, and these are both messenger RNA vaccines. This is a vaccine platform that has actually never before led to a licensed vaccine anywhere. And so this is a first, but the data are incredibly good, as you will see, and you probably have already heard. So the messenger RNA, when you make a vaccine, you have to basically develop a target antigen that the body is exposed to so that it can develop an immune response that will protect the individual when they're exposed to the pathogen in the natural environment. And so based on some early trials, phase 1 trials or preliminary trials, even pre-clinical trials, the scientists who work on vaccines, the vaccine developers, identified the spike protein in the SARS-CoV-2 virus that was probably the most important antigen to develop a vaccine to stimulate immunity. And so the spike protein is important for virus entry into the cell. Next, please. And so what are the advantages of an mRNA or messenger RNA vaccine platform? There are three issues: safety, efficacy, and the rapid response or manufacturing process. So the important thing to emphasize is that this is just a piece of the virus genome. It is not an infectious particle itself, and so the vaccine itself cannot cause disease. Secondly, what we're looking for is a very broad immunologic response, producing neutralizing antibodies as well as T cells that are effective in preventing infection and preventing disease, and allows for frequent boosting if necessary, although at this point in time, we don't know whether that's going to be necessary. And finally, from a manufacturing perspective, you want a vaccine that's relatively easy to produce and can produce it at scale and can produce it rapidly. And mRNA vaccines lend itself to this particular important attribute. Next, please. So someone's asked before this meeting, how does mRNA vaccine work? I'm not going to go through each of these pieces, but essentially you take the genetic code that basically produces the spike protein for the virus. You encapsulate it in a lipid nanoparticle. That allows it, you basically put it into a syringe, you inject it into the muscle. Once it's in the human body, it's taken up by antigen-presenting cells. The mRNA is then released in the cytoplasm, and then the mRNA actually makes the spike protein that we want, so that then that is released, and the immune system recognizes and begins to produce both specific antibodies to the spike protein, as well as T cells, cytotoxic T cells, as well as memory T cells and B cells that then become available if an individual is exposed naturally to the virus in the community. So that it's pretty simple. And as opposed to injecting a live virus, an attenuated virus, or a subunit virus, it's basically a little piece of genetic code that's very specific for the antigen that we want the immune system to react to. Next slide, please. So the two vaccines that are furthest ahead in this vaccine race are the Pfizer and the Moderna vaccines. They're both mRNA vaccines. They're two-dose vaccines that are given intramuscular. The Pfizer vaccine, the two doses are separated by 21 days, the Moderna vaccine by 28 days. The Pfizer vaccine requires ultra cold chain storage. It says here minus 70 degrees, but it's actually minus 60 to minus 80 degrees centigrade, or vice versa, minus 80 to minus 60. It comes in a multi-dose vial that it's shipped on dry ice, and then basically stored in ultra cold freezers. And these freezers can store this vaccine for months on end. Once you move it into a refrigeration process, you can keep it there for 2 to 8 days, for approximately 5 days at 2 to 8 degrees centigrade. And then once you take it out of the refrigerator and reconstitute it, you have to use it within 6 hours. So there is some flexibility in it, but there are some very stringent cold chain attributes. The Moderna vaccine is a little bit more easy to handle because it doesn't have to be stored or shipped in ultra cold storage. It can be shipped and stored at regular freezer temperature. Then you can store it in a refrigerator temperature of 2 to 8 degrees centigrade for up to 30 days. And then you have to use it within 12 hours, and it doesn't require reconstitution. And I believe that it's a 10-dose multi-dose vial. Next slide, please. So yes, so the first thing that I want to show is, what are the, well, I guess I didn't have the exact slide I wanted. The demographics here, you had about 43, could you go to the next slide, please? Okay, go back, please. Sorry. So the demographics here, this study, thanks, had about 44,000 individuals. And I can say that the two groups were equally balanced on the demographics that you want, both age, gender, race, ethnicity, and various other obesity and various other factors, so that we know that the two arms of the clinical trial, the phase 3 clinical trial that followed the phase 1 and 2 trials, the study subjects were basically equivalent. And that's important because you don't want to have any bias in sort of the balance of individuals within a particular arm of the trial. And so this phase 3 study was launched in late July. And as I said, they recruited about 44,000 individuals. These are the high-level efficacy results post-dose 2, 7 days post-dose 2. So the first dose is given on day 0, the second dose is given on day 21, and then they wait 7 days to get the maximum immunologic response, and then they begin to collect cases over time until the study hasn't really stopped, but until they basically ended the study in order to submit data to the FDA. And you can see here, if you look here on the right of your slide, you can see VE stands for vaccine efficacy. There were 8 cases in the vaccine group, and there were 162 cases in the placebo group. On average, these subjects in the trials in both groups were followed for an equivalent amount of time. And you can see that vaccine efficacy was 95% with a very narrow confidence interval. So this was very statistically significantly different between the vaccine group and the placebo group. Next slide, please. And if you look now at various subgroups, same endpoint 7 days after the second dose was given. And again, these were in subjects without evidence of prior infection. At baseline, they basically did serologic studies, and so they know these people were seronegative. They hadn't been infected with COVID-19 before the trial. And if you focus in on the various subgroups here, you see that, again, vaccine efficacy is pretty much 90% or over, almost 90% or over in many of these subgroups, whether they were older, and this is important because we know the older you are, the higher the risk you are for getting COVID-19. No difference in gender. When you look at the races, again, there were not as many cases in the Black or African American or other population, but again, efficacy was maintained over those groups. Same for ethnicity and in other countries as well. This was a study that was actually done in 6 countries, the US being one of them. Next slide, please. And further subgroups, you can see here, if you look down at various categories, let me focus in on the obese population, because in fact, that's a very high risk group for developing COVID-19 and having severe complications and death. And you can see vaccine efficacy didn't make any difference whether you were obese or not. It was close to 95% or higher in each of those categories. And even when you broke it down by age group, stratified of whether you're obese or not, the results were the same. So very, very good overall, amazing efficacy, frankly, overall and amongst the various risk subgroups. Next slide, please. And again, if you look at individuals who had comorbidities, pre-existing comorbidities, you can see here that those who had no comorbidity, the vaccine efficacy was 95%, highlighted in that box that says VE. And then they looked at various comorbidities, such as any malignancy, cardiovascular disease, diabetes, obesity again, and you can see again, vaccine efficacy was maintained, and as well as hypertension. So again, excellent vaccine efficacy for preventing disease, any disease, in those who were vaccinated compared to those who received saline placebo. Next slide. Next slide, please. Thank you. So now let's turn to safety and focusing initially on reactogenicity when we talk, no, go back, please. Back, please. Thank you. So we're going to focus in on reactogenicity, which is basically local injection site reactions. No, you keep going back and forth. Let's focus in on the first safety slide, please. Stop right there. Thank you. So when we talk about local injection site reactions, we have 3 things we look at. There's redness, swelling, and pain at the injection site. You can see here redness and swelling weren't really much of an issue. It was pretty much comparable in both the placebo. Sorry, this is looking at dose 1 and dose 2. Again, in those who were 16 to 55 and over 55, which were the 2 groups they looked at. And mainly the local injection site reaction that was of most significance was pain at the injection site. Compared to placebo, the pain was significant in the mild to moderate range, with really hardly anybody having a very severe reaction and no one having a grade 4 reaction, which is a really serious reaction. But you can see that the amount of pain at the injection site, the percentage of individuals, either those in 18 to 55 and those over 55 was quite significant. a little less in those who were 55 and older. So the older individual seems to have a slightly less local injection site reaction, probably because their immune system is not as functional as it is in a younger individual. Now we can go to the next slide, please. And here we have systemic events, again, within 7 days from dose one. Placebo here versus the vaccine. And the most common symptoms are fatigue, headache, and muscle pain. And the percentage is in that order, is highest in those fatigue, and then headache, and then muscle pain. And again, you can see that in most cases, the actual severity is mild to moderate, and a little bit less than in the older age group than in the younger age group for all three of those symptoms, but still a fairly high percentage as well. Next slide, please. And what I could say is for most individuals, the most common time that individuals would have either local injection site reactions or systemic effects was the second day after, the day following the day of vaccination. So on day 2 following vaccination. And again, here we're looking at post-dose 2 systemic events. Previous one was post-dose 1. And you can see that post-dose 2, actually fatigue, headache, and muscle pain were still the highest symptoms. And if you toggle back, I don't want to go back, but they're actually the percentage of individuals who sustained any one of these symptoms was a little higher after the second dose than after the first dose. So getting that first dose doesn't mean that you're going to have less symptoms after second dose. Your immune system probably gets primed with that first dose, and so that the second dose, you're going to have a little bit more reaction. Again, mild to moderate in nature and mostly occurring on the day after vaccination. Next slide, please. Okay. So this is actually, I'm probably going to, well, let me go through this very quickly. So this is a summary slide. If you focus in on the efficacy on the left, the conclusion is that the totality of the clinical data submitted with the EUA request from Pfizer meets the expectations and for the duration of follow-up. And I didn't say anything of that. All the manufacturers submitting a package for consideration for an EUA or for licensure in the future have to have followed up their subjects for a medium of at least 2 months, which was certainly met in the submission. And in fact, there were quite a few people who were followed for probably up to 4 months because the trial started in late July. The data was closed in the database was closed in November. And so some people who were vaccinated early in the trial were followed for up to 4 months. In the final efficacy analysis, vaccine efficacy 7 days post-dose 2 was about 95% in individuals who had no pre-existing COVID-19 as determined by baseline serologic testing. The efficacy in subgroups was mostly over 90% in all the subgroups. And again, vaccine efficacy, although I didn't talk about that, actually there was some vaccine efficacy after the first dose. Now, I do want to highlight that there's no indication right now or evidence right now about the durability of the vaccine. How long will the efficacy last, either after 1 dose or after 2 doses? And then when you go to the safety side of this slide, I already went through that, but essentially the vaccine is considered to be, the tolerability profile is considered to be excellent. There were no significant adverse events to speak of, except there were a few people in the vaccine group got Bell's palsy, but they weren't done, they didn't have this in a cluster fashion, so it was over time. And it's uncertain whether, in fact, this is related to the vaccine or not. There were no differences in deaths between the 2 groups. I think there were 4 deaths in the placebo group and 2 in the vaccine group, all thought to be unrelated to the vaccine. And so what we have here from a safety profile is basically local injection site reactions, mostly mild to moderate in nature, that are most significant the day after vaccination. Next slide, please. Next slide, please. So finally, this is the process by which the approval and recommendation of the vaccine progress. So yesterday was December 10th. If you look on the bottom left hand of the slide, the Vaccine and Related Biologicals Products Advisory Committee to the FDA, or VRBPAC, made its recommendation to the FDA. And the recommendation was, and I'm going to read it, based on the totality of successful evidence available, the benefits of the Pfizer-BioNTech vaccine outweighs its risk for use in individuals 16 and over. The vote was 17-4 with 1 abstention. So this was approved. It made the news this morning. If you didn't listen to the media or watch the news, you wouldn't have heard it. But if you do, normally when you wake up in the morning, it was all over the news. The next step is the FDA now has to issue the emergency use authorization. It'll have to develop and finalize the package and the letter that it sends to the manufacturer. This is expected to occur tomorrow, Saturday. We're hoping for that. Once the manufacturer receives the letter, it will then the Operation Warp Speed will begin to ship vaccine to states to pre-position some of the vaccine in selected hospitals around the state and around the states. On Sunday, actually today, the Advisory Committee on Immunization Practices is going to meet to also review the data that was presented yesterday at the FDA. They will make their own recommendations on use of the vaccine. And they will vote on that probably on Sunday. They will not vote on their recommendations until after the EUA is issued by the FDA. So if FDA issues on Saturday, ACIP is expected to vote on Sunday. The ACIP is advisory in nature. It makes its recommendation to the CDC director. The CDC director then has to accept the recommendation and sign it, essentially. And then it has to be published in the CDC's Morbidity and Mortality Weekly Review in order to become official policy of the CDC and the Department of Health and Human Services in the government. And so once that recommendation is issued and CDC officially issues its guidance, that's when hospitals can begin to start vaccinating their targeted population. And in this case, it'll be phase 1A, which is healthcare workers and individual residents of long-term care facilities. And after the CDC guidance is published, vaccine will begin to be shipped to other hospitals where vaccine was not pre-positioned, and not until that CDC guidance is published will that happen. And I think with that, that's the end of my presentation. Thank you.
Great. Thank you so much, Dr. Bresnitz. There are a number of questions for you that we've received, and we'll be sure to have some time to address these during our question and answer period. Our next presentation will be a summary of post-vaccination safety monitoring by Ms. Noelle Bissett, a surveillance specialist with the Vaccine Preventable Disease Program of the New Jersey Department of Health. Ms. Bissett, you should be unmuted and ready to go. Thank you.
Great, thank you. All right, next slide, please. Under the EUA, there will be 3 main groups that will be reporting adverse events: the vaccine recipients, the vaccination providers, and the vaccine EUA sponsors. Reporting will be voluntary for vaccine recipients, mandatory from vaccination providers, and there will be monthly periodic safety reports from the vaccine EUA sponsors. The FDA and CDC will also be working together to coordinate and share data. So providers will be required to report vaccination administration errors, whether they're associated with an adverse event or not, serious adverse events, any cases of multisystem inflammatory syndrome, and cases of COVID-19 that result in hospitalization or death after the recipient has received a COVID-19 vaccine. In addition to the required conditions, healthcare providers will also be encouraged to report any clinically significant adverse event that occurs after vaccination. Next slide. There are 2 different methods of tracking adverse events that will be utilized. First is VAERS, which is an existing mechanism, and BSafe, which is a new one. VAERS, or the Vaccine Adverse Event Reporting System, is co-managed by the CDC and FDA, and is on the nation's frontline, is the nation's frontline system for monitoring vaccine safety. There's also a link on the bottom of this slide to New Jersey Department of Health's VAERS webpage, which directs you to the main VAERS webpage. Next slide. Adverse events in VAERS are reported through a fillable form that's found on the VAERS website. VAERS accepts all reports from all reporters without making any judgments on causality of adverse events. Some of the key strengths of VAERS are that anyone can report to the system, and it can rapidly detect safety issues, signals, and rare adverse events. Additionally, the data is available to the public, so anyone can go on and search reports of adverse events. One of the main limitations of VAERS is that since reports are received from all providers, there can be reporting bias and the possibility of inconsistent data quality. And in addition, as I mentioned before, causality generally cannot be assessed through the reports provided in VAERS. Next slide, please. The second method of tracking adverse events is vSafe, which is a new smartphone-based active surveillance system for COVID-19 vaccine safety. vSafe uses text messaging and email to initiate web-based survey monitoring. Health checks are conducted on vaccine recipients daily for the first week after vaccination, and then weekly thereafter until 6 weeks post-vaccination, with additional health checks at 3, 6, and 12 months post-vaccination. Anyone who reports into vSafe a clinically important event during that health check will receive a phone call from VAERS. And if applicable, a VAERS report will be taken during that call. vSafe will also collect information on pregnancy status, and that'll also enable follow-up on pregnant women. Next slide, please. So this slide shows the integration of vSafe, and with vSafe check-ins occurring, so that's on the top, the check-in occurs, and then follow-up is conducted by phone for any clinically important events. And those clinically important events include, but are not limited to, missed work, someone being unable to do normal daily activities, and anyone who receives medical care. At that point, the call center gives the patient a call, and a VAERS report will be taken and entered into the VAERS system if applicable. And I think that is my last slide. Thank you.
Excellent. Thank you so much, Ms. Bissett. Our final presentation for today's session will be an overview of New Jersey's phased approach and phase 1A eligibility. That's presented by Ms. Amanda Medina Forrester, the Director of the Office of Minority and Multicultural Health. Thank you so much for being with us this morning.
Thank you for having me, Mary. So to get us started, the three main goals for my presentation will be who will be vaccinated in New Jersey, where can they get vaccinated, and how they can get vaccinated. And again, I really want to stress the importance of these Project Echo sessions and really grasping that and sending that out to many stakeholders as you can to ensure that information is getting to you. Next slide. So this is just a picture of what our amazing PAC, Professional Advisory Committee, has worked on for many, many months, many hours throughout this process. So within this whole time frame, we will start, if you look from mid-December, starting yesterday, I believe, to spring. So our first group will be our phase 1A, healthcare workers and long-term care residents. And then it moves up to phase B, 1B, other essential workers. Phase 1C, adults 65 years of age with high risk medical conditions. And then phase 2 is the general population. So I just also want to note, with the healthcare workers, there are over 650,000 healthcare workers here in New Jersey. It's one of our fastest growing, our largest industries here in New Jersey. So this is the one group that we are very mindful of and we want to take care of. Next slide, please. So of course, this is all recommended by ACIP. This is not something that each state is doing on their own. We are following the ACIP guidelines through the CDC. And to make the importance of healthcare personnel and long-term care facility residents on who they are and why they are a priority group for phase 1A. Healthcare personnel includes all paid, unpaid, serving in a healthcare setting who have the potential of direct or indirect exposure to patients or infectious materials. So it is those high-risk locations such as hospitals that have a high exposure and transmission to the COVID. It's also early protection of these healthcare personnel because they are our industry. We need these healthcare workers to be as strong and healthy as possible to meet the demands of New Jersey's surges. So it is critical to preserve the capacity of care to these to our patients by protecting our healthcare staff. For the long-term care facilities, we saw a very dramatic decline with, dramatic increase with SARS, with the COVID pandemic. And of course, this is really important to us in New Jersey to ensure that these residents, our long-term care facility residents, are a priority. So it's adults who reside in facilities that provide a range of services, including medical and personal care, to persons who are unable to live independently. So it is residents, and it's also, of course, their staff. Of course, just like the healthcare personnel, they are in high-risk locations and at high risk for infection and severe illness due to their age and due to high rates of underlying medical conditions, especially living in congregate living situations. So again, this is the why it's important. Healthcare personnel and long-term care residents and staff are a priority right now. Next slide. So I kind of want to talk about who are those healthcare workers. So it would be healthcare workers that are in hospitals. So it's volunteers, paid, unpaid hospital workers. It's also those long-term care workers, those volunteers and residents. And it's all other healthcare workers that are not part of a facility or a hospital who also work, volunteer, spend their time working in a healthcare facility. So the long-term care facilities and the other settings are examples of where people work. So it's not where they could get vaccinated, but it's actually where people actually work. So for instance, for the long-term care facilities, it's the skilled nursing facilities, veterans homes, assisted livings. For the other settings, it's people who have exposure because of their work, ambulatory care, dental, emergency medical services, funeral homes, harm reduction centers, pharmacies, link agencies, hospice centers. These are all workers that work in these settings that are incredibly important to us. And we need to make sure that we're taking care of them, putting them in the 1A group. And again, this is not an exhaustive list. This is just examples of what we have for you right now. Next slide. So who is considered a healthcare worker? Again, paid, unpaid persons who work, volunteer in healthcare settings that have direct or even indirect contact with people who are infected and materials. For instance, as obvious as those doctors, those nurses, pharmacists, dentists. But it's also other staff in a facility. It's those facilities managements, the security guard, the food services who brings food to the patients. Admin, it's the budget procurement person who sits in the back, who's making the hospital run smoothly. The receptionist, the language interpretation service person, the laboratory technician who's working on those films. So again, it's all those areas in a facility. It's also the people outside that facility. It's those community health workers, navigators who are working with the communities, the promotoras, our doulas, our midwives, our health educators in the community, and of course, all the public health professionals. It's those students that come in and work, countless of hours, volunteers, the essential caregivers who are unpaid but are taking care of the patients and their loved ones. The vaccinating staff and contractors. And it's also the emergency medical services, the paramedics, funeral staff. So again, the list goes on and on and on, but these are just examples of who are considered healthcare workers. Next slide. So this is just a sample of what our expected costs associated with the vaccine will be. So for the consumer, we want to ensure that it's free of charge. We want to eliminate as many barriers as we can to access the vaccine. So it would be free of charge for all consumers. The administration costs will also be free of charge. For the providers, it'll be free of charge from the federal government if you're following the federal pharmacy program. The administrative costs, though, will be a reimbursement of $16.90 first dose and $28.40 for the second dose is what is expected. For those insured, to be billed by a private insurer, Medicaid, Medicare, and other insurers. For the uninsured population, to be reimbursed through the Federal Uninsured Fund managed by the Health Resources and Services Administration, or HRSA, which has already been covered with the cost of the care of uninsured COVID patients across the nation. Next slide. And so I also want to give some guidance and some information about our public confidence building. So the Commissioner of Health and many of our leaders have given over 3,000 stakeholder engagement calls across federal, state, local leaders. We've been having stakeholder calls with healthcare providers, our professional associations, our community-based organizations, faith-based organizations, unions, and a lot of other stakeholders to ensure that everybody's getting the same messages for access. Everybody will have access to the vaccine. It is a multi-pronged public health awareness campaign led also by our commissioner that will be launched in December. And this campaign will also be targeted for different stakeholders as well in multi-languages, over 12 languages in different variety, low literacy, to ensure that everybody understands the efficacy, safety, and any concerns they have with the vaccine prior to the access. They will also have a vaccine webpage updated constantly to ensure that the CDC information is getting filtered to us and sent to the residents as well. So that's going to become available pretty soon. We have a provider survey, which we find very, very helpful. We analyze that, our great team of analysts analyze that. They look at consumer confidence surveys. They have launched across the call centers, and then they continue to look at survey call volumes through our help desk to ensure that we are meeting those demands and answering those questions. Another piece is qualitative research or qualitative work that we're doing. We've had over 12 listening sessions across the state in regards to our stakeholders. We want to know their attitudes, their perceptions of the vaccine. What is keeping them from getting vaccinated? And if it is, what barriers do they have, and how we as the Department of Health could strategize to diminish those barriers as much as we can. And then of course, we just launched our weekly newsletter. The commissioner is very fond of this, and this is something we really want to push out as much as we can. It was launched December 4th. It keeps us abreast of all the information coming out as it comes through CDC. And we definitely want to be as transparent as possible to share that with everybody. Next slide. This is a snapshot of our Vax Matters. Again, you know, the link is down there. Please, if you can, share that with your stakeholders, share those with your staff. If anybody has questions, there's a contact number, website to go on to. But again, it will probably have the most updated information. It does update every Friday. So again, just have that link ready and save it, favorite, and then click on every Friday afternoon. Next slide. So these are just our key resources. We have in our website, we have our CDC interim vaccine playbook. Just like Dr. Bresnik said, it's changed dramatically, but it's something as a start. We have our CDC checklist for best practices for vaccination clinics, how that satellite, temporary, or offsite locations. Our CDC vaccine storage and handling toolkit, which is very useful to you as providers. Our CDC skills checklist for vaccine administration, CDC epidemiology and prevention of vaccine preventable diseases, a New Jersey COVID vaccine plan, the New Jersey vaccine plan executive summary, which is it's a snapshot of the very large vaccine plan. So please look at that to get a snapshot of what New Jersey plans to do. And then of course, our library of a lot of great resources that we are building as CDC brings this information. Next slide. And that's all I have. Thank you so much.
Thank you so much, Ms. Forrester. This is excellent information, and we hope to be able to share that after our presentation today as well, so that anyone dialing in will have access to those important resources. So this concludes our formal presentation portion of today's ECHO session, but we've really allotted an extended, we've got 30 minutes now for an extended question and answer period. As a reminder, we are going to be documenting all questions, and we hope to begin to use these as a starting point for drafting a frequently asked question document that should be available sometime after our call today as well. So I want to start off first, if our panelists could unmute as appropriate. I'm going to start with Dr. Bresnitz. We received a number of questions. We've seen it through the question and answer today, but also pre-submitted. Can you talk a little bit about if an individual has already had COVID-19, will they be eligible to receive the vaccine, or should they receive it?
That's a good question. We have had so many people who've had COVID-19, and most of them have survived, thankfully. There were some patients in the Pfizer trial that basically had COVID-19 previously, although that wasn't determined or detected at the beginning of the study. So we have some data on that, and they were vaccinated, and they didn't have any adverse events that were any worse than most of those who were in the trial who were COVID-19 negative. The CDC has made some statement about this, saying that essentially that those individuals should probably and may want to basically wait at least 90 days from the time they were first diagnosed. I mean, clearly, if they're ill, there's no place for them to get vaccine when they're actually acutely ill. And of course, if they survive, they're going to have an immunologic response. They're going to be protected. We don't know how long they're going to be protected because you can get reinfected. And so that's important for people actually who've gotten natural disease to be vaccinated in the future. But the guidance is about wait at least 90 days before you actually consider getting the vaccine. I do want to say, I saw a lot of the questions. I want to just remind people that they can go to the FDA website. All the presentations that were made there yesterday are accessible there. You can see the Pfizer presentation, you can see the FDA presentation with all the data, and you can, at your leisure, review all the data and may answer some of the questions that might not be addressed today.
Sure.
I also want to say that I only presented data on the Pfizer data because the Moderna data have not been really made public except what's available in the press release. Next Thursday, VRBPAC is meeting again. We're going to go through the same process of seeing that data as well. And we'll have more to say about that once we actually get a chance to deep dive into their data.
I think that's a great point. And really the Pfizer data, to my knowledge, was only published in the New England Journal as of yesterday with a really nice editorial that accompanies for framing. So I think another important resource potentially. What is known with regards to duration of immunity at this point? I know there's been lots of concern and talk about how fast this process seems to have happened, but what do we know as far as duration of protection?
Well, we don't know a lot because the trial began in late July, July 27th. So we only had follow-up for a few months, really, up maybe about 4 months. There were no reports of anybody who got reinfected after vaccination, and so we don't have any data on that. We really don't know the durability of the vaccine after one dose, because some people, most everybody who got one dose got 2 doses, and it's going to take some time before we have that durability. The plan by Pfizer and all the manufacturers that are conducting phase 3 trials is to follow their study subjects for at least 2 years. That's the requirement by the FDA. So, we don't know, to what extent, whether it'll be, if there is a drop in vaccine efficacy, what kind of drop, what the rate of drop might be, if there'll be any drop at all, we'll have to see. I do want to answer a couple of questions. I took a look at them if I could. Just people asked about particular conditions about whether they're eligible, in addition to whether they were COVID positive or not. So there's a lot of interest in pregnant women. This Pfizer those individuals were excluded from the study, and there's really not a lot of data available pregnant women. There may have been a few that became pregnant during the trial, but there's just a paucity of data because they were excluded. The FDA, from my understanding at the meeting yesterday, is not going to make it a contraindication because they don't really have any data, and they're probably going to be somewhat silent on that, and we'll have to see what the ACIP recommends. But the bottom line is the FDA person stated that if someone's pregnant, they can consider it in conversation with their practitioner. We'll see if the ACIP echoes that, what the FDA stated. And if they do, they'll probably make it a shared clinical decision-making recommendation for pregnant women. There were some questions about cancer. Some people asked about why is the vaccine efficacy only 75% in that subgroup, and whether those cancer patients in the study were actively being treated or had cancer previously. I don't know the answer to the second question, but if you look at the numbers in the subgroup, I think there were only 4 or 5 people in that subgroup who actually had malignancy and who had got disease either in the placebo group or in the vaccine group. And if you look at the confidence interval, it's very, very wide. So the reason it's 75%, it's a point estimate, and it's a very unstable estimate. There was a question, there have been some questions about people who are immunocompromised. Those people who are immunocompromised were excluded from the trials. So we have no data on use of the vaccine on immunocompromised patients. And it's unlikely that that will be in the EUA as well. Similarly, the Pfizer did have some patients who were HIV positive or hepatitis B positive or hepatitis C positive. They began to recruit those individuals later in the study, so they don't have a lot of cases on that. And these are people who were stable with their disease. There are some plans to gather more information on those individuals, and I don't know what the EUA is going to say. We'll have to take a look at that. And finally, or 2 points, you don't have to quarantine after you get vaccinated. That's one of the questions. And secondly, what about transmitting virus? We know that the outcomes that were assessed in the Pfizer study were about efficacy in preventing disease or severe disease. But there are no data just yet about preventing transmission of the virus, which is very important, because if you can prove that when you get vaccinated that viral transmission is prohibited, then you're more likely to get herd protection or herd immunity much more quickly than if you're just trying to vaccinate individuals in the population. Those studies Pfizer's doing some work on that, and the CDC is also planning some post-EUA studies that will assess that particular issue as well in terms of effectiveness studies. Thanks.
And Dr. Bresnitz, I think that's really important information. As a provider and as an immunizer, where should we be referring individuals who have these specific scenarios or specific situations? Should it be a triage to their primary care provider to participate in that shared decision-making process regarding risks and benefits?
Yeah, shared clinical decision making means making a decision together with your healthcare provider, whether it's your primary care physician, or whether it's your specialist physician, if you're being treated for a particular underlying disease by a specialist. Either way, it's up to the two individuals or the individual with their family members and the treating physician to make that decision together, weighing the risks of the vaccine that are going to be largely unknown in that population versus the known benefits of the vaccine in preventing disease.
Sure. I'm hoping Amanda is still with us. Amanda, if you're there, I did have a question with regards to how we saw this come in from our pre-submitted questions also. How will healthcare providers who are in the 1A group, but who are working outside the hospital or long-term care setting, how will they have access to the vaccine?
Yeah, that's a great question. So right now, our Department of Health has a pod and logistics work group, and they're working very hard with hospitals and other stakeholders to develop pods. And I know right now we couldn't present it because it's still, nothing's been finalized yet, but we will have these points of delivery throughout the state. And that will be a way where a lot of the non-hospital employees could have access to that as well. And then also the hospitals, some of the hospitals will be becoming also open pods, while they could also open their facilities to those other non-hospital employees. So yeah, so we are definitely working on those logistics 24/7. Our pods team is like nonstop. So more to come on that.
And I know you reviewed
Sure. Hi, I'm the policy advisor for the department. Pleased to be with you all. Just to build off of Amanda's point, we're definitely, with that pods and logistics team, really trying to expand the diversity of the locations. It's going to be somewhat limited at the onset as vaccine scarcity it exists. And as Dr. Bresnitz shared, some of the Pfizer product in particular has such a delicate sort of storage and handling sort of requirement. So it does limit our capacity to set up, for instance, in private practitioners' offices. We just aren't, given the volume of vaccine and given the size and the handling, it's hard for us to do that at this time. However, if you are, and with so many healthcare providers sort of on the line today, if you are interested in becoming a point of dispensing, either in the near term or in the longer term, there's information about how to start that sign up process online. Certainly we have to evaluate the best ways to deploy very scarce doses, but just want to flag that that network, to Amanda's point, is very much expanding and will continue to expand into 2021.
Great. Thank you so much, Jennifer. And my apologies for not introducing you sooner, but Jennifer Fearson is joining us as a policy advisor to the Department of Health also. So thanks so much for chiming in there. Amanda, you mentioned a little bit about the pricing and the cost associated with the vaccine. Should individuals be prepared to present their insurance card or any practical aspects about how this dispensing process will take place?
Yeah, so I'm going to turn that over to Jennifer, who's much closer to that than I am. Jennifer?
Yeah, Amanda and I very much tag team this work. And yes, to the extent possible, we're hoping to have individuals be billed through their insurance. As Amanda shared, we expect that no cost will be passed on to the consumer from that billing. We're really looking to leverage existing billing systems in our points of dispensing. So really work with our hospitals and FQHCs and others to sort of go through their normal sort of billing processes. And we'll certainly be working closely with our points of dispensing on any questions that arise on that sort of like back end side of things.
Sure. Thank you. Noelle, I hope you're still with us. I see your video is muted, but if you're still there, hey, thank you. I just wanted to ask, if someone receives a vaccine, do they still have to practice social distancing, and do they have to still wear the mask? Because I think after so many months, people are looking at this like, potentially some good on the horizon. So can you sort of explore that?
Yeah, I think Dr. Bresnitz sort of touched on this, but at this point, of course, we hope that down the line, CDC will develop additional guidance and hopefully be able to speak to social distancing and mask wearing. But at this point, basically, the answer is there's not enough information for CDC to say stop social distancing, stop wearing masks, because we just need to understand more about what kind of protection the vaccine will provide before that decision is made. So other factors, including how many people get vaccinated, how the virus is spreading in communities, all of that will play into these decisions. So basically the answer is at this point, until we have enough information to say that social distancing can be relaxed and mask wearing can be relaxed, that recommendation would still stand.
And sort of just to piggyback a little bit more with regards to this timing of the second dose. I know that we received a couple of questions with regards to the two-part process. We know that vaccines tend to not work if you shorten the duration between the intervals. We saw a number of questions with regards to what if you get the Pfizer product for your first dose and then only the Moderna product is available. Can you or Dr. Bresnitz maybe talk about the importance of timing or reminders we can offer for individuals electing to become immunized?
Sure, I can start and then I can pass it over to Dr. Bresnitz. So the products are not going to be interchangeable. So the individual's second dose will have to be the same product as the first dose. And I know he touched on the timing. So the two products right now, Pfizer is 2 doses separated by 21 days. Moderna is 28 days between. And making sure that second dose is scheduled as close to that window as possible is ideal to achieve optimal vaccine effectiveness. So, we would encourage providers to try to schedule that second dose when they have the person there for their first dose. I don't know if you have anything to add, Dr. Bresnitz.
No, well, we'll have to see what the EUA says. Typically, as Noelle mentioned, or Mary, as you mentioned, there's a short window of giving a second dose in a multi-dose vaccine series too soon. There are some guidance for the typical childhood vaccines. But then usually if it's longer than the specified interval, we usually say, well, give it when you come in. So 21 days is for the Pfizer vaccine, but if they came back 2 weeks later, we just give it. We wouldn't probably start over again, but we'll have to see what the guidance provides. And that's not unusual. I do want to underscore what Noelle said about the importance of basically doing all the things that we've done so far to prevent transmission of diseases that are non-pharmaceutical in nature, like wearing a mask when in public, washing your hands, social distancing, even getting testing. When you get vaccinated, remember the vaccine efficacy is amazing. It's 95%. It's true in most groups, but it's not 100%. So you don't really know 100% that you're protected when you get the vaccine, okay? And if you only got one dose, you're less protected. Secondly, we don't know, as I mentioned earlier, whether the vaccine prevents transmission of virus. So you could get infected, have the virus in your nasal pharynx, not get sick because the vaccine prevents disease, but you could still transmit it to other people. So it's really important to continue all those measures until we get guidance. And really, it's going to take many months before we're going to see any consideration of revising that policy by the CDC and by the state, for that matter. I mean, really important.
Really great point.
Remember, just think about vaccine as another tool in our prevention toolbox, just one other tool that we're beginning to launch. And that tool is going to take some time before everybody can touch that tool and get the benefit of that tool.
Great, and any of us who have been immunizers know that. I mean, those are recommendations we've historically used come flu season. This is comfortable because we've heard those recommendations before about the importance that the vaccine is another option. I want to revisit this question of adverse effects. We had a number of questions trickle in with regards. Can you just reiterate, Dr. Bresnitz? I heard you say that the most common adverse effects were injection site, and that potentially that there in the data, it looks like maybe younger individuals, younger than age 55 were at increased risk, or but it sounded predominantly like injection site reactions and local things.
Well, that is always usually the case with any vaccine, but I don't want to understate that there were also, a significant percentage of people both with the first and the second dose who got systemic reactions as well. Fever, headache, muscle aches, those were quite significant as well. And in older individuals, that might have a little bit more of an impact because they already may have other infirmities, so that when they get fever or they get chills or they get muscle aches, they're more impacted than a younger individual. And again, there's 2 doses, so they can expect to have the second dose. And it's true there was a difference between the age groups, but it wasn't a huge difference. It's, if you're older, you're going to have less likelihood of having it, but you can still have it in any case. I want to emphasize again, people are a lot of questions about immune compromise. There's really no data on that. And so it may be shared clinical decision in a lot of individuals. So stay tuned for that information.
And I believe the side effects, of course, are going to be, coming out in the EUA and things like that, but we'll likely expect that those will vary between the different products as well.
In general, they'll probably be the same.
Okay.
Local injection site reactions and the systemic reactions are fairly typical of vaccines. So I think that, from a categorical perspective, they'll be probably about the same, but from a numerical perspective, they're never exactly the same. One other point is that people have asked whether they need to get baseline antibody tests or antigen tests, and then post-vaccination antibody antigen tests to see if it worked. And the answer to both questions is no. So yes, it's true, you might have been asymptomatically infected in the past, and so you don't know whether you were infected previously. And if we did antibody tests on you, you might show that you were previously infected. But again, as I said, and so if you're asymptomatic, we obviously don't know when you might have been infected. And so there's not this 90-day waiting period. And there's no reason to get tested before you get vaccinated to see whether you had antibodies. And then once you've had that second dose, given the level of efficacy, there's no reason to get antibody tests to see whether you've actually had the immunologic response. That's going to be expensive, and it's not going to really give you that much information.
Let me ask you also, it is still influenza season. If an individual, is it safe for someone to receive immunization with the COVID vaccine in conjunction with the flu shot or the pneumococcal vaccine at the same time? What are your recommendations and thoughts about that?
Yeah, that's a great question. I mean, I think that even more generally, it's about getting any vaccine that would be indicated in individuals 16 and over. And there was a question about whether 16 or 17-year-olds can get it. And yes, it's just a matter of when they could get it. Pfizer didn't study this. They didn't do it concomitantly with other vaccines, so we have no data. Typically, you do concomitant or concurrent studies to see whether one vaccine interferes with the immunologic response of the other vaccine, or whether you have an enhanced adverse event. So there are no data on that. Pfizer is planning to do that, I imagine, in the future. I imagine the other manufacturers are as well. But right now we don't have any data. I would say to be cautious is that since the vaccine is given either 21 or 28 days apart, depending on the vaccine, I would not get vaccinated in between. I don't think the CDC has given that guidance yet. I imagine they will, just so that it doesn't complicate the picture. You just basically wait, either get it beforehand, and that's what I would advise, because we're already well into the flu season. If we're talking about flu vaccine, don't wait till after, because the flu season could be over by the time you get the COVID-19 vaccine. And as for other vaccines, I would say the same thing. Don't get it in between the 2 doses.
Sure. And even simultaneous, although we try to do that sometimes for improving compliance with immunization. I think no way, because difficult to tease out if an adverse effect occurs. What was
Correct.
it also? Amanda, I want to get back to you. We had a number of questions come up with regards to cultural sensitivity and being really receptive to our patients who have concerns about the vaccine. How as healthcare providers can really we address cultural or ethnic issues that may cause patients to really be hesitant and say, well, no, I'm not really willing to accept this?
Yeah, that's a great question. So it kind of goes back to class. Culturally and linguistically appropriate services, standards that all healthcare providers follow. So following those standards through everything we do. And then of course, being very ultra sensitive with this vaccine and how we educate. So it's providing a very basic education on why the vaccine is important, why it's important to your family, and of course, just driving down the education for the patient and not assuming the patient is fearful or not fearful. Is really important. Also having staff to speak to that person in their language that they're comfortable with. Somebody who looks like that person is really important, who understands that resident is really important. So using those class standards would be my first response to that great question. And then of course, the Department of Health will be publishing some great information, some good quality education materials for patients who have diverse backgrounds. So of course, we'll be following about 12, 13 languages. We'll be translating it, ensuring that health literacy standards are looked through a panel of health educators who have this expertise, a lower literacy, numeracy, ensuring that we are listening to those communities. So it's not just the education, but also engaging those communities. And so right now we are working very hard with some community stakeholders to look at what could help educate, finding those stakeholders, those gatekeepers, the faith-based organizations, the community-based organizations, who are the communities turning to, and then having ambassadors go to these communities and to definitely have this one-to-one. So it's going to take a village. It's not just the provider. We don't want all the onus on the provider, but we definitely want to have a collective education where our community stakeholders, our faith-based stakeholders, our leaders in communities are engaged through the whole process as educators for this vaccine as well.
Excellent. Thanks so much. It's such an important factor, I think, here. I'm interested to hear about the availability of education in different languages. I think that's a critical aspect here. And yeah. I wanted to follow up because my understanding is that there won't be a vaccine information statement available for this vaccine, but that the availability of other plain language guides to inform individuals. I don't know, Amanda or Dr. Bresnitz, if you can sort of weigh in about the type of education. I always found that to be reassuring, to be able to give that to a patient or a vaccine recipient before injecting them with something, just to ensure that this disclosure of information has really taken place. So any guides or tools that will be available?
Well, yeah, well, first of all, as part of the EUA that the FDA will issue, They have already been working together with Pfizer to develop what's called an EUA provider fact sheet, which is quite extensive. It's much more technical, and then a patient fact sheet. And that patient fact sheet has to be handed out to the potential patient or vaccinee. They may not all be patients, just individuals. And they basically are provided with that. It's obviously in understandable language, hopefully. I don't know how many languages the federal government will translate these into. The manufacturers probably has no obligation to translate it into many languages. I know the CDC is planning to basically translate a lot of its information into 5 different languages. I know English and Spanish. I don't know the others. And I know we as a department are planning to translate a lot of our resources into many languages. I don't know yet about the EUA and how many languages that will be translated into by whoever, by the CDC. And then that's a very narrow answer to your question. A broader answer is there's a lot of communication and a lot of education that will be going on over the next months. And the education communications is going to change as we progress through this vaccination campaign, as we learn more things, as issues develop. There really is a very large and complex and comprehensive communication plan that the department has developed. But, this is, I think you used the term, it takes a village. That's obviously a common phrase, but it will take a village to spread the word about the vaccine and its benefits and its risks, and encourage people through very culturally and ethically sensitive language to encourage people to get vaccinated. We know there's a lot of hesitancy out there, differs amongst populations, and I think it's important for us to keep our eye on the ball of how to basically get to individuals and address their personal concerns about the vaccine, because that's what's going to get people, and to address their personal concerns by the right people as well. I know we only have a few minutes. There were a couple of answers. If I could I want to very quickly answer, if that's okay. First of all, someone asked, when does the authorized vaccine become a licensed vaccine, or the manufacturer has to collect enough safety information over time, at least 6 months, before they can file for a BLA, a biological license application. Everybody wants this to happen as quickly as possible, including the manufacturer. It's going to take probably about 6 months before that happens, is what I would say. Secondly, someone asked, is it a one-time vaccine or is it every year? We don't know, because we don't know the durability at this point. Third, vaccine in children, those studies will have to happen. I don't know when they'll be completed. Probably not before the summertime is what I would expect for when I say children under the age of 16. And then finally, there were a couple of questions about people with Bell's palsy. That was a factor in the study. It was amongst the vaccinees. We don't have a lot of details of that. One of the individuals had a previous history of Bell's palsy. I know that. I don't know whether the 4 individuals recovered or not. That was a question from one of the individuals. And finally, the anaphylaxis issue, which was reported out of the UK. Now, the UK, they had a couple of people, both of whom had underlying history of anaphylaxis, one to food, the other one to some unknown drugs. And then there was a third case potentially who had some sort of anaphylactoid-like reaction. The UK really went far and said, okay, anybody with a previous history of these allergies shouldn't get vaccinated. That's not what the FDA is going to say. The FDA is basically going to say, if you've had some reaction to something in the vaccine, then you may not need to get vaccinated. I don't think they're going to go as broad as the UK did. It's highly unlikely. And I'll stop there.
Thank you. I think those are important points. And it reminds me that we're all going to be tuned in this weekend. We know a day is a year in the time of COVID. And certainly this is going to be a long weekend for all of us as we stay tuned for this additional information. Jennifer, did you want the last word?
I just want to tie a few things up in that. I know there were some questions in the chat about when will it be available to me? I think that Amanda did a great job of sort of describing how this is. We're building sort of a stepwise process. I know that many of you on the line are healthcare workers, and so you'll be eligible in phase 1A. Phase 1A is a phase, it's not a day. While we hope to be able to start inoculating people next week, and we're hoping to start fortifying our hospital-based staff and others, we are readily building out into the community. There's going to be a lot of vaccine coming to the state of New Jersey in the next month and into 2021. And we really hope that as counselors of your patients, as potential vaccine administrators, as consumers yourself that you'll all partner with us directly and indirectly to help sort of spread the message and take this information back to your patients, colleagues, and communities.
Excellent. Thank you so much, Jennifer. Thank you to our panelists today. I think this was an excellent, informative session. I want to be respectful of everyone's time. We promised we'd conclude at 12:30, and that is the case. Again, thank you to all for joining us and for participating. This session has been recorded, and we will be distributing it after our call. Our next session, addressing how to get vaccinated in phase 1A, is going to take place this coming Monday, December 14th at 11:15 a.m. Please be sure to register and to join us at that time. Thanks again, everyone. Enjoy your weekend and be well.